Hi guys, it's mdepintochild44, and here we're going to do our infant medical assessment. So for our call, we are called to the home of a 3-month-old with difficulty breathing. So we would hop on the ambulance and determine what PPE we're going to wear, in this case, gloves, to start. Then I would be determining what I'd like to bring into the residence with me to take care of this child. In this case, a pediatric bag and jump bag and oxygen. So when we arrive on scene, I'm checking for scene safety, which in this case, there doesn't seem to be a reason for it to be unsafe. So I would be walking into the house after introducing myself to the mother. The patient is found in mom's arms, slightly lethargic, wheezing audibly without auscultation. Mom states that she's been dusting and the baby started to cough. She called when she started to make weird sounds and seemed to fall asleep, becoming harder and harder to wake up. Now, based on this alone, I want to get this child out of the environment that caused the respiratory complication. So I'm probably going to have us bring everything back out of the house and move to the ambulance, because if this was due to dust or some other breathing component, I want to have clean air for this child to start to breathe. So I would ask mom to hand me the baby as politely but quickly as I could, and carry the baby out in my arms to the ambulance, where we would check her airway. In this case, airway is patent. I would begin by listening to the fact that this is a life threat. I would begin by listening to her lungs, even though I heard auditory wheezing without auscultation. I want to get this baby on oxygen as soon as I can via non-rebreather, and I would likely have my partner call medical control to see if we could administer albuterol, due to the fact that it sounds like she's wheezing, so her airway she's slowly losing lung movement. It's tightening up. So as we move along, I'm assessing heart rate, and trying to keep the baby awake if I can, watching how she's breathing, if she's gasping, if she's struggling, if her lips are blue, if she's becoming cyanotic at any point. I'm trying to wake the baby and keep her alert. I would start with my voice, as I would with anybody else, and then touch. And if she's not waking to that, then I would probably pinch her toes for responsiveness to pain. In this case, she's responsive to pain, and her airway is patent with respirations 26, even though she's wheezing in all lung fields. Her heart rate is 160 at the brachial. So in my version of assessment, I've taken an apical pulse, even though I will check PMS in all 4 extremities. And I will take blood pressure using an infant blood pressure cuff. She's breathing fast and shallow with wheezing. Mom states that the problem has been going on for about an hour and she's getting worse. So I'm glad that we got here when we did. And having her on oxygen, we will hope that she will improve as we go along. But as we're assessing and monitoring, my partner and myself would take a sample history from mom, where the baby is lethargic, as we noted, with no known allergies. pediatrician was evaluating for possible asthma. So my assessment and measures so far have been kind of on par with a diagnosis of asthma, having contacted medical control for use of albuterol through a nebulizer. She last nursed 2 hours ago, which is perfectly within a window of understanding. And the dust is very likely the agitator. So on oxygen, her lung sounds are remaining the same. Her respirations are 28 still, or actually they've increased by 2. Mom is panicking and crying, but baby's good weight, clean, well cared for. I'm looking for signs that the baby is maturing or growing at a healthy rate, if I could. And I'm going to do an APGAR, very likely. Medics are 10 minutes out, the hospital's 4 minutes away. So I'm definitely going to try to rapidly transport this patient with mom's permission. I would be reassessing every 5 minutes. If the patient further deteriorates, I'm going to first try for an oral airway, and then, actually, no, I'm changing that. First, I'm going to go with BVM and see if I can improve her air exchange, her oxygen exchange. And then if that's not working, then I'm going to probably go for an oral airway or a nasal airway. So on arriving to the hospital and speaking to the charge nurse, I would go down my list as follows. So I have an infant, approximately 3 months old, with difficulty breathing on presentation, suspected asthma attack due to possible prior history of asthma being assessed ongoing, that I called for albuterol, and that the patient has been deteriorating despite oxygen on a non-rebreather, and we are oxygenating using a BVM, that they are not on any medication. They're not on any medication with no known allergies, regardless of the fact that they've been assessing for asthma. And then I would deliver the last known vitals of respiration rate 28, breathing shallow but regular, at a heart rate of 160. And that would probably end my report. I may not have mentioned, I would have put this infant on the stretcher with padding on all 4 sides to keep her or him in a neutral position, with the head elevated slightly to promote breathing, to make it a little easier on this child. During transport. Thank you for watching.